Welcome to today's presentation. Dr. Silva and Dr. Rakiro will be joining us, but we have quite a bit of ground to cover, so we'll just start. So we'll cover the non-ischemic strokes with particular emphasis on ICH, SAH, and CBLT, and a mention of genetic syndromes, just because it's not covered specifically in any particular class. And I think Dr. Carol, at least for the part 2 class, or they covered part of cases regarding the genetic syndromes or other rare strokes. So we'll start with this case presentation, and just I need to keep your legs.
Okay, 21-year-old right-handed male, has medical history, asthma and ADHD, treated with methylphenidate, found in gym bathroom with left side weakness and urinary incontinence shortly after lifting weights. At arrival to the emergency department, he was following commands with left hemiparesis. He complained of severe headache. Initial laboratory studies revealed a normal platelet count, coagulation profile, and negative toxicology screen.
So a young male with no clear risk factor who's coming with an acute onset left hemiparesis. This is his CT scan. This was from it was a sort of a test report. So this from this CT scan, you can see in this non-contrasted CT, you can see in the right frontal lobe. So I repeat, this is the right, this is the left. In the right frontal lobe, you can see there's a huge hyperdense lesion with surrounding edema with a midline shift and obliteration of the lateral ventricles on the same side. Indeed, there is also effacement of the sulci on this side if you compare it with this side. The midline shift, as I mentioned, midline shift with this pointed in the red arrow. And in this, you can see in the CT angio that there was a prominent terminal vessels in the middle aspect of the right frontal lobe. Yeah, you can see this, the white dotted lesions suggest that there are vessels that contributed to the pathology of this patient. So it basically suggested that there was an intravenous malformation that resulted in this acute intracerebral or intraparenchymal hemorrhage. So, question: what clinical and radiologic features of this case suggest a secondary cause of ICH? It is not related to great question.
Just define what is secondary.
So, secondary, okay, we'll be looking at the causes of intracranial hemorrhage in the subsequent slides. But basically, when you talk of secondary causes, we are looking at anything that could have precipitated the hemorrhage, aside from, okay, just suppose this was a primary cause. I don't know to preempt the list of the causes of intracerebral hemorrhage. It's in the third slide from here. But yeah, so what do you think suggests in this patient that there could have been, that it is there's no secondary cause? Okay, it's loud silence. I leave that question hanging. We'll answer it shortly. So I'm handling the intracranial hemorrhage in this man, and you can see intracranial hemorrhage is a constellation of very many different findings, from subdural to extradural hematomas to lobar hemorrhages, as you can see here in the frontal lobe, to subarachnoid hemorrhage, to deep intracerebral hemorrhage. So there are very many different types, but in this case, we are dealing specifically with intraparenchymal hemorrhage, which has etiologies, as you can see here. And here now you can be able to differentiate between primary and secondary causes. So from hypertension, trauma, amyloidoangiopathies, advanced age, cocaine and methamphetamine use, hemorrhagic disorders, neoplasms, and vascular malformations. All these can cause intraparenchymal hemorrhage. Indeed, for that patient, all the factors was suggestive of the fact that he did not have a secondary cause that was probably primary from his history and his radiologic findings. So the commonest, or probably the most prominent in this list as a cause of intraparenchymal hemorrhage is hypertension. But don't forget the other ones, especially in patients who present particular history or in a particular age group. And hypertensive bleed.
Cause is protection.
Oh, okay, yes. The commonest cause of primary intracerebral hemorrhage is hypertension, but the commonest cause overall is trauma. So I talk about trauma, hypertension, and hypertension is has locations which suggest hypertensive intracerebral bleeds, and they are highlighted there. The only part that's not highlighted there is the cerebellum. So from the putamen to the caudate nucleus, or the rest of the basal ganglia, to the cerebral peduncles, and then with the involvement as well of the cerebellum. So those are the usual locations of hypertensive intracerebral bleed, and when you find patients present with the bleed in those locations, and it should trigger the thought that this could be a hypertensive bleed. So they present differently depending on the location, and I think these are important to know different ways in which they'll present. So maybe I should just go back here. I'm sure you already stolen the question, but could anybody point out one of the locations and try to explain to us what could be the common presentation in such scenarios? Anyone? Like you can choose the putamen, you can choose the thalamus, you can choose the cerebellum. How do you think the patients should present if they had intracerebral bleeds in those locations?
So for the thalamus, you can have, just like in the skin, you can have either pure sensory, where they may present with numbness on one side. If it's involved in one side, you can have a pure motor or a sensory motor. So the motor aspect may be involved, or both sensory and motor on the side effect side.
Thanks, Carol. Abu, you sound like you're next.
Cerebellum.
Cerebellum is.
It's a lateral ataxia.
Yeah.
And depending on how far it extends into the brainstem, we get other associated features depending on which particular cranial nerve nuclei are involved. On the ipsilateral side, it's contralateral sensory deficits.
Okay, like if you have a Vega syndrome, for example. And I think dizziness and ascent is prominent in vomiting. Any other? None of us, yes. Okay. Same. Okay, so I'll take you through them just again in emphasis. So putamen will get contralateral, so the rest of the C/L is contralateral. They don't get so contralateral hemiparesis, slant speech, and the IDP is still from the side of the hemiparesis. And if it's large, you start getting brainstem compression. Patients with thalamic bleeds, as Dr. Carol pointed out correctly, we have prominent sensory deficits, but you can get overlapping syndrome. You can get hemiparesis, you can get in the dominant thalamus, patients can present aphasia and constructional apraxia on the non-dominant thalamus. If it extends upward to the midbrain, you can get ocular disturbance. On time, I think it's quite clear usually from its anatomic information that you get deep coma with quadriplegia, pinpoint pupils, and other signs of autonomic disturbances. And then in the cerebellum, Dr. Aboda mentioned well. And then when you get the lobar hemorrhages, depending on the location, you may be able to pick where is the location of the bleed. So occipital, you give the hemianopia, left temporal aphasia and delirium, parietal hemisensory loss, and frontal giving you arm weakness, frontal headache, and vomiting can occur. So let me get to the pathogenesis of hypertensive bleed. And basically, what happens is that in chronic hypertension, it causes a small vessel vasculopathy, which is characterized by lipohydrosis, fibridoid necrosis, and development of facial aneurysms. This affects the penetrating vessels like the reticulostriates, thalamoperforators, paramedian branches of the basilar arteries. So all these vessels, when they are affected by the vasculopathy that is occasioned by the hypertension, become at risk of bleeding in the presence of sustained elevated blood pressures. And so there'll be predilection to the sites that we have mentioned before, including the basal ganglia, the lobar regions that I've mentioned, the thalamic, pons, cerebellum, and other brainstem sites. So, 54-year-old, hypertensive, non-compliant, I'll move that image, acute right-sided weakness with BP of 221, 15 GCS is 14. What will you do? You'll do something. The CT scan is there. What will you do?
Start one.
Call neurosurgeon. Start with hypertensive. Elaborate on it. You know what I want to hear, like what are your targets and things like that.
Targets.
Yeah. I think kind of just
Decrease in 20% in the 20 left up like 20% maximum decrease in the 24 hours, or target of just like about 1
Okay, so actually the thing is, if the blood pressure is between 160 to 180, you want to bring it to a systolic of 140, and then you can titrate after about 24 hours. Then you can optimize the blood pressure control. But if it's more than 180, then you want to lower it by 20% of the systolic blood pressure, at least for the first 24 hours. So. According to the American Heart Association guidelines for ICH in 2015, so if the systolic is around 150 to 220 actually, and then you lower it to 140, and more than 20 infusion and frequent BP monitoring, and the targets are mentioned in the next slide, which I'll show you. So, question about reversal of anticoagulation and role of fresh frozen plasma in case of patients who have bleed when they are on anticoagulation. I'll mention that as well in a slide. And so basically that BP is elevated in most of these patients on admission. So it's a question. So when we look at the guideline, the recommendations, so there was suggestion as to whether or not it should be given. So the answer was that it doesn't have tranexamic acid.
So yesterday, I was looking at your slides at about 11 o'clock at night, and there's froze somewhere in between, and then I gave up.
The what?
The froze somewhere in between.
Oh,
so
the froze. Okay. No, this slide was added by Dr. Sophie.
Oh.
Yeah, this one was added by Dr. Sophie. So,
okay.
Yeah. So that's why I did correct the translation. Why did they freeze? Okay. Okay, fine. So the question is the hypertension the precipitant of the hemorrhage? Is it a reflection of chronic hypertension? Is it an attempt by the physiology to maintain the cerebral perfusion pressure? Is it sympathetic activation secondary to pain and anxiety? And what has been noted that it actually tends to return to baseline about 7 to 10 days post the ICH. So the overall point is that most of these patients, absolute majority, will have elevated blood pressure when they have intracranial hemorrhage. And so in terms of how you manage the blood pressure, it's you depend on the baseline blood pressure, the age of the patient, and the presumed cause of the hemorrhage. And of course, if there are features of raised intracranial pressure. So how fast should it be lowered? So different guidelines. I mentioned the guidelines from the American Heart Association. These are other guidelines suggesting that you should lower the mark by about 15%. That does not change the cerebral blood flow, but if you go to more than 20%, there's alteration in the cerebral blood flow, and that's why the guidelines suggest that a reduction of less than or about 20% should be what is achieved in the first 24 hours. And in this case, you should use the short-acting and rapidly acting and IV antihypertensive, just because of the fact that if you notice that the pressures are going too low, then if you're using a short-acting agent, then that allows you to titrate more accurately. Dr. Tina mentioned that you can use labetalol, and the other options include hydralazine, esmolol, nicardipine, and enalapril. Enalapril, yes. Clearly, through cardiology. So sodium nitroprusside and nitroglycerin should be used with caution because of the vasodilating and potential elevation of the ICP. So the recommendation is use ideally non-vasodilating antihypertensives.
What about hydralazine?
Is it a centrally acting as well? I'm not sure if it causes vasodilation in the central nervous system. In the central. It's not ideal. So, I mentioned most of those points, and with regards to in the presence of cerebellar hematoma, there are recommendations regarding these sizes depending on the locations of in different places. But I picked for cerebellar hematoma just because presence of a hematoma within the cerebellum, if it's more than 3 centimeters, it is an indication for it to be evacuated, and 1 to 3 centimeters is to be carefully monitored. Different quantity of blood or different quantity of bleed is a risk for death. In fact, in the brainstem, like in the pons, more than 5 mils is associated with mortality, and in the cerebellum, up to 30 mils is associated with mortality. So you can see there is not cerebellum, in the cerebrum. The cerebrum, more than 30 mils associated with mortality. So
this one is the fossa, posterior fossa is small. That's why cerebellum needs to control of it. That's compared to
the cerebrum.
So it has 3 centimeters of cerebellum.
Cerebellum is 3 centimeters. Is the indication for evacuation. The other ones I was talking about in terms of volume. So that is about mortality. So there's more than 5 mils within the brainstem is a high risk of mortality, and more than 30 mils of blood in the cerebrum is a risk of mortality. So I added the slide with regards to anticoagulation associated intracranial intracerebral hemorrhage. And basically the question is, if these patients have been on anticoagulants, what should you do? Basically, the aim or the goal is to reverse the INR to normal range. So three different recommendations. So there is high dose vitamin K, about 10 to 20 milligrams IV infusion. Recall that it takes at least around 6 to 8 hours for you to be able to notice the effects of vitamin K. And the good thing is it helps to achieve the sustained reversal of the INR. You can also use fresh frozen plasma or the prothrombin complex concentrates as alternatives in reversing the anticoagulant effects in patients who have intracerebral hemorrhage. So in that bullet where there was a question about the role of the FFP, so this is where it comes in patients who have had who are on anticoagulation and are having intracerebral hemorrhage. Yeah. So. Good question. So some of them these days they are reversal agents. I think you've heard of it from me. The biggest one, for example, so they are novel, so they are probably types.
For the biggest I think this is one, yeah. Okay. And for the others,
It's called a drain.
sorry.
A drain.
So it's Nexen. I'll just read to you. It's Indexanet. Yeah, Indexanet. So
Is it available locally?
No. Actually, it's not. It's not. We need the full results of the trial have just been published in the literature in last week. Yeah. So it's. I think it's I'm not sure if it's even registered in all the jurisdictions. But so in terms of reversal, actually, we have reversal agents for the new anticoagulants, and we don't have a reversal agent for warfarin. All these things we're talking about are actually not reversal agents because they don't work very well. They don't. They're short. They take long to work. So if you give vitamin K, you see how long it takes, in fact. Yeah. But with the new reversal agents, because they are targeted, they work rapidly, very rapidly. And indeed, they're associated with thrombotic events as a side effect. And so there's a distinct morbidity and mortality from the thrombotic side effects, in addition to the benefit from the reversals. So the plan is to have at least one dose available in A&Es in Nairobi. That was what there have been discussions about that. Please just
One question I didn't idea which I found quite challenging to answer is in the case of intercerebral hemorrhage in patients on anticoagulation, with in the background of continued risk for prothrombotic events. So it's a good example is patients with permanent atrial fibrillation with significant cardiovascular risk factors who have intercerebral hemorrhage when they are offering. So at what point in the management do you restart the anticoagulation?
So the question has been answered in terms of is it worthwhile restarting or not, and the answer is obviously yes. So the data now will show that even patients who have suffered an cerebral hemorrhage benefit from anticoagulation. There is a net benefit. There will be a risk of hemorrhage, but there is a net benefit in the study. In terms of timing, certainly 3 months on, but there are situations where you can start even as early as 2 weeks.
There's a patient we managed it was hemorrhagic transformation.
Right.
And there was a paper from Middle East, which was a case presentation, and they advised to start and build up slowly. And there is no real guideline to start by saying, but you realize you might start, let's say 40, build it up by Saturday night, give it a week, build up to treatment goals. The other way is you can put carotid filters with patients with neurotraumas, if we are able to do that. Yeah. But build up slowly. Usually it might take even 4 months building up to the desired dose.
Or you can consider like a left atrial appendage closure. The next subtopic in our discussion is the subarachnoid hemorrhage.
Before we go there, what happens is sometimes when there is a lot of massive hemorrhage, a surgeon can go in, give thrombolytic agent and aspirate. That I've seen we have done. We give thrombolytic agent and aspirate the reduce the volume of the hemorrhage. That gives a chance to the patient.
There is also the studies in which they have actually done evacuations of the superficial large bleeds rather than deep bleeds. There is a benefit from surgery. But deep bleeds there is no benefit from surgery.
Okay. I mentioned in the internal hemorrhages that one of the subtypes is the subarachnoid hemorrhage, which is a true neurological emergency. Basically, it's a result of extravasation of blood in subarachnoid space, and usually leads to what is described by patients as a thunderclap headache, the worst headache of their life. But there are other ways in which it can present. So it can present either with that history of a thunderclap headache, or others they usually have symptoms that are then quickly followed by loss of consciousness, which means that then you may not be able to adequately get the history of what happened. So then somebody may report that they actually had some complaints, and then shortly after that they changed the level of consciousness. And of course, the third is when it happens so suddenly that there's loss of consciousness without any preceding complaints or symptoms. Those are the differentials for thunderclap headache. I just added them there because I think it's important when always considering that subarachnoid hemorrhage is at the top of that list, but there are other differentials as we have talked about in previous classes. So the commonest subarachnoid hemorrhage can be due to trauma, can be spontaneous or non-spontaneous, including due to trauma or due to or secondary to cerebral hemorrhage. So like can get patients with cerebral hemorrhage with extension into the subarachnoid space. But the more common is in the primary spontaneous subarachnoid hemorrhage is the aneurysmal subarachnoid hemorrhage, which will be what we'll be talking about more in this discussion. The non-aneurysmal subarachnoid hemorrhage forming about 20% of the spontaneous type, and these usually 50% of them are said to be perimesencephalic, which is an entity that in itself. But we'll mostly concentrate on the aneurysmal type of primary spontaneous subarachnoid hemorrhages. the epidemiology is skewed more towards women, and usually it occurs before the age of 65. And the immediate mortality of aneurysmal subarachnoid hemorrhage is up to 30%. So it's a significant cause for patients who have sudden death, those who have sudden mortality after complaints. And survivors have a recurrence rate of about 40% in the first 4 weeks and 3% annually thereafter. So it's really quite it causes quite significant morbidity and mortality. It's an important entity.
That's because the commonest age group is between 40 and 60.
40 and 60.
And mortality, patients who reach the hospital, 50% will not reach hospital. And within 1 month, 70% have breathing. About 50% who reach to the hospital, 70 have breathing. Out of that, 50% also reach. Therefore, that is why the guidelines are very strict. Act immediately. Within 48 hours of bleed, you should have treated these patients. Usually 24 hours.
So actually, the mortality and morbidity is probably bigger than even reflected in my bullets there. But note this, I said it's before 65, so most things happen at the age of 65. Just remember that the epidemiology of SAH is more in the younger groups. So the associations are with regards to formulation. So I call the associations of those who have the risk factors for getting aneurysmal bleeds. So you can either get the risk factors for the formation of the aneurysms or for the rupture of the aneurysms. I mentioned that I'll concentrate mostly on the aneurysmal SAH. So formation, the risk factors that are listed there. So there's the hypertension, smoking, female gender, because it is more predilection towards that, chronic alcohol use, and the family history. And then there's the inherited diseases, especially the collagen vascular disorders that again predispose to vasculopathy and vascular malformations. So adult autosomal dominant polycystic kidney disease is really strongly mentioned to be associated with aneurysmal SAH. Rupture is associated with being Japanese or Finnish in the female gender, smoking, hypertension, cocaine abuse. Posterior circulation aneurysms are at a higher risk of rupture, and giant aneurysms. So basically, if you look at the rupture, one of the things that was mentioned is that most of the times the rupture or the onset of the symptoms will be at a time when the patient was having like Valsalva kind of maneuvers. So when they have increased excitement, increased sympathetic, or increased activity, that usually surrounds the time of the onset of the symptoms in these patients. So I want to look into the morphology.
Something that is of importance, but 10% of them actually occur during sexual intercourse.
Then when they come to diagnosis, sometimes can be a challenge, not only when you actually have that performance picture. So you do an contrast CT, but the yield from the CT actually goes down with every procedure. So you find that the highest yield is in the first 6 to 12 hours, and then it goes down to about 92 for the next 24, and down to 85 for the next 14. So the first few hours are the review the greatest yield in terms of imaging. And then you need also to do your CSF studies. You know the one in 4 where you take it in zero. You can do spectrophotometry, so but I don't think you have that yet.
So we have to do it once, and then after that it disappears, that service.
Yeah, but you can actually do your 1 in 4, and you can actually quantify the RBC. So as opposed to traumatic, it should actually remain the same or increase, as opposed to traumatic, it can really goes down. And then now you can actually get your yield all the way up to 2 weeks after the event. So it's still important to do your CSF.
And the other thing that is more recently that has come up in terms of diagnosis is that if you do a non-contrast nice CT scan with the modern machines within 6 hours of then you really probably don't need to do a number crunch to exclude that surviving hemorrhage because it's negative probably.
I tell you that lumbar puncture is done. If you have high suspicion of headache, CT scan is normal. And you see suspecting ignorance, that's an indication of lumbar puncture. Not all patients are that.
Okay.
And the reason why from description from what Dr. Hugo has said, the yield goes down because of vasospasms. Therefore, if you do the initial assessment, there is no evidence of aneurysm. You are supposed to repeat after 14 days when the vasospasm has gone.
Thank you. So that's the morphology. Skip it because we have quite some distance to cover. So I'll move a bit faster. So yeah, circular, fusiform, and dilating aneurysms. Those are the different types, and up to 90-95% of the circular aneurysms actually occur in the anterior portion of the circle of Willis. So you can see actually the anterior communicating artery has up to 30-35% involvement. Okay, my pointer is missing, and then the other aspects are also involved, and you can see the different locations, especially with regards to the circle of Willis. So it basically just to tell you the predilection in terms of the occurrence of circular aneurysm specifically. When these patients arrive, there is clinical grading scales that are employed to be able to quantify the clinical damage, so that in terms of correspondence and understanding between doctors, and also for surgical consideration. So the Hunt and Hess classification is probably the commonest, and also we have the World Federation Neurological Surgeons classification. So Hunt and Hess classification is as noted there. So it's the patient is worsened with the higher grade. So grade 1 is asymptomatic or minimal. Grade 2 is moderate to severe headache with some nuchal rigidity but non-neurological deficits. Grade 3 have mild deficits. Grade 4 they have they could be vegetative or RED cerebral rigidity with moderate to severe hemiparesis. And in grade 5 they have deep coma, decerebrate, and moribund appearance. So the point in this is that the utility of the outcome in surgery is good for patients who, or should I say, like patients who are grade 4 to 5 tend to have poor outcome whether or not they undergo surgery. So it's usually a question of knowing the grade prior to the surgery in order to be able to explain whether or not the patient will benefit from neurosurgical intervention. The alternative usually is the World Federation of Neurological Surgeons classification, which is as well as mentioned, they're using the Glasgow Coma scale and then noting with the motor deficits. Okay, I'll move to the pathogenesis and explain it very briefly. Basically, AVM is a factor of the stress factors that cause changes in the wall of the vessels, and then resulting in the pathology that then you get. So they are the stress factors from the fact that you have an aneurysm come from the hemodynamic stress in terms of the.
It's more about aneurysm than AVM.
Yeah. Actually, it's for aneurysms actually. So I'll make that correction. So hemodynamic stress, aberrant flow conditions, as well as oxidative and proteolytic oxidative stress cause changes on the wall of these vessels. So what happens in the wall is you get degeneration, you get thrombosis, you get cell death, and a matrix degradation, and all this predispose the vessels to bulges, to aneurysms, and to rupture. So that is basically the stress in terms of the alterations in the flow and the causing changes on the wall, and then predisposing to the rupture of the aneurysms. So the complications that occur, as Dr. Mativo mentioned, rebleeding is an important factor because it occurs in quite a significant percentage of the patients. Hydrocephalus, both acute and delayed, vasospasms and hyponatremia, and I'll mention them subsequently, starting with hyponatremia. So I put this slide just to show you the mechanism of how they get this cerebral salt wasting kind of syndrome. It's basically because of accumulation of both atrionatriuretic peptide and brain natriuretic peptide. So eventually these patients get a hypovolemic hyponatremia, which is important because the recommendation is against free water restriction because it actually increases the risk of stroke. So that is free water restriction should not be used in trying to correct the hyponatremia. I'll talk about the management of hyponatremia shortly. So in the terms of the diagnostics, so patients coming in, I think this is like a summary slide for most of what happens with SAH, coming with symptoms or with a typical presentation, either typical or atypical, then the immediate plan is to do head CT scan without contrast. So if there is subarachnoid hemorrhage, then CT angio or cerebral angiography. CT angiography is recommended, and if there is aneurysm, then prompt treatment. If there is CT cerebral angiography is normal, then this is recommended to be repeated in 1 to 3 weeks to include also the imaging of the brain, the brainstem and the spinal cord, because sometimes the limited CT angio may not be able to pick lesions in the higher parts of the spinal cord and to the brainstem. If at the time of presentation you do a CT scan without contrast and there's no subarachnoid hemorrhage, then this is the time, as Dr. Mativo mentioned, that lumbar puncture will be indicated. And here, if the lumbar puncture is normal, then you will stop. But if it's abnormal but equivocal, then you will do CT angiography and again continue in the same manner. And if it is the lumbar puncture is unequivocally abnormal, that means you see the xanthochromia with the elevated distal count and change from tube 1 to tube 4, then that should again prompt you to do the CT cerebral angio. So basically, this was to juxtapose the point that Dr. Mativo had made earlier with regards to the indication for lumbar puncture and the fact that lumbar puncture increases the yield in terms of diagnosis of subarachnoid hemorrhage when added to image.
Actually, I don't know the deadline of CT angio because CT angio will take up to around 92%. 92%. MRM will pick up to 72%. I get the teaching is conventional for the study or is I don't know.
That's for patients with after.
No, that for patients it's a straight aneurysm.
After aneurysm.
I don't know where the slide of CT angio will go from because the deadline is DSM or conventional for.
What I saw in some of the classes that if the CT angio does not pick the aneurysm, then you do the DSA because it will be able to pick some of the lower aneurysmal findings that the conventional CT angio will not be able to pick.
As Dr. Luka said, if you do your CT in the first 6 hours, the yield is very high, it's 92% to 100%. But if you delay, that's when now you find the yield goes lower. And if you don't find the initial CT non-contrast initially, then you can go to a conventional and they are much more invasive.
Those are good goals.
Yeah. But when the patient comes, just do a non-contrast CT at the start. And many times you actually get your diagnosis, but you're not going to go.
The question that was asking.
We are all saying the same thing. So first question is there a subarachnoid hemorrhage? The answer is
yes.
To answer that question, we do a CT scan, plain non-contrast. Yes, there is a subarachnoid hemorrhage. Problem solved. If that is normal and you still suspect there is a subarachnoid hemorrhage, then go ahead and do a lumbar puncture, do all the things that you do. At the end of the day, if you decided, yes, there is a subarachnoid hemorrhage, you need vascular imaging. Now, the quickest, easiest way to do vascular imaging non-invasively is a CT cerebral angiogram. And so it's a measure to help you decide, okay, this is an aneurysm, it's an AVM, this is the location, if you find it. So let's say it's positive, you have an aneurysm, then the next thing to do is to manage that aneurysm, isn't it? That's where the vascular neurosurgical interventionist comes in, make a decision, okay, I'm going to do this endovascularly or surgically. If that imaging is negative, the vascular imaging on CT angiography or MR angiography is negative, that does not exclude an aneurysm. It can be deferred imaging, or if you're suspicious and you think there is something that needs to be acutely sorted out, then the patient will go into the cath lab. And that's what Dr. Majid was saying, that the gold standard is still digital subtraction angiography. Yeah? So proper standard for vessel, integral puncture or medial puncture. Yeah? So that's what you need to do. Now, as far as treatment is concerned, the treatment obviously, so the CT angiography, properly done with a good machine, can give you, and with good interpretation, can give you a guideline whether you go surgical or you go endovascular. So that is why you see Dr. Mogere looking at it, studying it, and then making a decision. And then if he decides he's going in, he's going in. Endovascularly, he goes in endovascularly. Obviously, that way, then he can define the anatomy better and make a decision on the table. He can call it, do that right away. Yeah. Is that helpful in terms of clarification?
Thank you, and it also mentions the management. So just move to this. What are the high risk factors?
Sorry, one other thing. So you can either coil or clip aneurysms at the moment, but there are newer techniques being developed to try and manage aneurysms. But at the moment, the main two techniques are coiling and clipping.
And we need to know which aneurysm you can coil or clip. Is there any difference?
Sorry?
Do we need to know which aneurysm you can coil or clip? How do you know?
I think you need to know, because you're a stroke specialist. But everybody else, I think in terms of, no. On a serious note, even for me, it's difficult to make that decision. So I leave that to the vascular neurosurgeon. So I can say maybe this one may require surgery, but at the end of the day, it's the vascular. And even for a general neurosurgeon, it's difficult. So we are really blessed to have a vascular neurosurgeon, and indeed a vascular neurosurgeon with dual training in interventions and surgery. So it really, at Queen's there used to be a multidisciplinary meeting to actually make that decision. So there would be, the interventionalist or the interventional neuroradiologist and the neurosurgeons doing vascular work would meet together with the radiologist and make a decision. Yeah, and we used to sit in on those meetings just to learn how. But you learn general things, but some of the discussions can get quite complex.
That mentioned, so risk factors, high risk factors for surgery include aneurysm in the posterior circulation, like in the basilar region, advanced patient age, large or giant aneurysms, past history of ischemic cerebrovascular disease, and symptomatic aneurysms other than rupture. So those are high risk in terms of surgical outcomes. So in terms of medical treatment, it mostly talks about the complications and how they are managed. So one of the complications is vasospasms that occur in these patients. So there are postulations as to what causes the vasospasms around the site of the subarachnoid hemorrhage, the irritation itself by the surrounding leaked blood to the vessels in that territory may induce the vasospasms. And basically the recommendation is that daily transcranial Doppler may be useful. But in terms of therapy, nimodipine has been shown to reduce morbidity from delayed ischemia due to vasospasms. And basically because it causes the delayed ischemia, not in fact a change in terms of the frequency of the vasospasms themselves. And other CCBs have not been shown to have a similar kind of benefit. So it's not, we cannot extrapolate it to other.
So actually the dose is 60 milligrams every 4 hours? Yes.
4 hours.
6 times a day, yeah. And there's been a recent paper presented in the stroke meeting where we wanted to single dose. And so that's something we do.
It should be used orally, not
Yeah. Okay. There's no role for giving antiepileptic drugs in those without a seizure, but those with acute seizures may continue up to 6 months with prophylactic antiepileptic drugs. And then the hyponatremia, I mentioned about the causation of hyponatremia in these patients. And recommendation is that they should be careful monitoring of the sodium levels, maybe OD or twice daily in the first 2 weeks. And if it's found and it's in patients with symptomatic vasospasms, and it is still with 3% serum. So if you have symptomatic vasospasms with hyponatremia, then that's an indication to give hypertonic serum. The other common complication is hydrocephalus, which can be acute or chronic. So acute is usually non-communicating type, and there's a recommendation that you should differentiate this from vasospasms and hyponatremia. And the treatment is ventriculostomy with CSF drainage for selected patients, and chronic hydrocephalus. Usually the non-communicating type is non-communicating type, and treatment is with lumbar puncture, ventricular drainage, or surgical insertion of a PP shunt. So just remember the common complications and the medicine therapies. Quick, what do you see? This image. This image.
So there's a bleeding on the left.
Okay.
The effacement of the sulci and the midline shift.
Okay. What else do you see?
We don't see the ventricle.
Okay, fine.
You wouldn't see the ventricle.
Yeah? Shape. Okay, I'll point this out because of time. I'm lacking time. What do you see? Where the... So there's hyperdensity in the subarachnoid space, yes. Yeah? Okay, and what do you see? Suggestive of CVST. So in this one picture, it captures the three things we are looking at today, and that's will move me to the next one, which is the CVST. So yeah, so there's evidence of subarachnoid bleed, there's intrathecal bleed, but there's also cerebrovascular thrombosis. So the first reported case was in 1925 of CVST by a French physician called Rips. He reported that there was a patient who was 45-year-old, came with headaches and seizures, and subsequently autopsy done, they noted that there was thrombosis of the superior sagittal and lateral sinuses. This is the oldest reported case of somebody who was suspected to have succumbed to CVST. A few years later, John, the physician to King George IV, reported a case of a 24-year-old woman who, 2 weeks after completed delivery, developed headaches and multiple seizures. She succumbed to the status epilepticus, and thereafter the autopsy revealed thrombosis of the superior sagittal sinus and cortical veins. And you may understand that at this time the novel imaging that we have now was not present, and so it was difficult to pick this non-invasively patients presented with CVST. But subsequently, widespread availability of CT venography in the later 1980s and of MR venography several years later has enabled non-invasive diagnosis of CVT. When you use CT venography, you can actually get correct identification in the sinus of 99% of patients with CVST, and in the cerebral veins about 88%. So, and then there's a bullet to note. So CT venography is probably the more available in terms of accessibility. But when MRV, when used to pick the CVST, it's probably even more accurate, especially in picking the cerebral venous thrombosis. And here, the contrast MRV has been mentioned to be more sensitive than the time of flight MRV, particularly for sinuses with small diameter or where there is low blood flow. I will skip the anatomy and the mention, but I think it's generally clear. You have the sagittal sinus, you have the inferior sagittal sinus, which, when joined by the great vein of Galen, will give you the straight sinus. And when it joins up with the superior sagittal sinus, they reach the confluence of sinuses and then drain towards the jugular vein. And the straight sinus is usually joined also by the transverse sinus. Just general anatomy, but you can go through it in detail later to note the different veins that can thrombose. In terms of the pathophysiology, it's basically an initiation and then maintenance of the imbalances in the thrombotic and the antithrombotic processes in the body. So when there is systemic or local imbalances in this, maybe occasioned by things like dehydration or any other alterations in the blood flow, then you have venous blood flow venous blood flows into the small vessels, and this increases the venous and capillary pressures. And if there is insufficient recruitment of the collateral pathways, which occurs in most of the scenarios, so that this is avoided, but where there is insufficient recruitment, there is disruption of the blood-brain barrier and reduction in the cerebral perfusion pressure, which may cause cerebral edema, local ischemia, and even intracerebral hemorrhage. That gives you then the complex presentation in terms of the patient's presentation. And parenchymal lesions occur in up to 60% of these patients. And what is noted that this is actually quite different from the parenchymal lesions that you will expect in patients with arterial strokes, because they'll cross the arterial boundaries, and the 2/3 will have a hemorrhagic component. And often you get both cytotoxic and vasogenic edema. I think the pathology of many other diseases to talk about the different kind of edema that you can get in the brain. And dural sinuses aid in CSF absorption, and so when you get blockage, then you get arachnoid dysfunction, and that contributes to physiology pathogenesis of increased necrotic pressure due to the increase in the CSF in the ventricles. The presenting symptoms, commonest is headache, followed by papilledema and seizures, symptoms and signs. Then there are others as listed there. And the complications, the three commonest mentioned are the hydrocephalus, which occurs in up to 15%, and then intracranial hypertension and transtentorial herniation, which is the main cause of early death, the main early cause of death in those with CVT. This slide was to highlight what the syndrome or the presentation will be like depending on the location of the thrombosis. So I'd like to mention the superior sagittal sinus will present with the motor deficits and the seizures, and the different locations may give you different kind of presentation. So cavernous sinus, for example, thrombosis, you'll get the orbital pain, the cranial nerve pulses of the nerves that pass within the cavernous sinus, orbital pain, chemosis, proptosis. That may occur with cavernous sinus thrombosis. So and the rest as well are mentioned in the slide there. So this again is a slide I can quickly go through, but which you can as well go through later again even more comprehensively. So if you have confirmed CVT, then the question is whether there is impending transtentorial herniation based on your clinical findings and on the imaging findings. And here the recommendation, of course, is to do urgent decompressive hemicraniectomy. If
you can remember you're planning a patient with cerebral
if there's none, then initiate low molecular weight heparin treatment. And this is preferred to, unfortunately, heparin, except in cases that I'm going to highlight. And intracranial hemorrhage due to CVT is not a contraindication for heparin treatment. It occurs in so many places you read, so I think it's an important point to remember that you need to anticoagulate. We are anticoagulating. Anticoagulation is anticoagulation. So search for underlying etiology. So that includes things like associated risk factors like hereditary thrombophilia and systemic disease like cancer. And screen for hereditary thrombophilia can be considered, but rarely changes the management. So this again is contentious from some other guidelines, whether or not you should look for this. And I'll show that slide just next. So then if there are complications, then you manage them, especially the three that I mentioned. So hydrocephalus, intracranial hypertension, transtentorial herniation. If there are no complications, then you can initiate oral anticoagulant when the patient is clinically stable, and dependent on the underlying etiology, you will continue it generally for 3 to 12 months. In another way, in this slide, I emphasize that thrombophilia screen is done for those with past medical history or family history of venous thrombosis who are young and with no risk factors. Malignancy, no. D-dimers, no. From Dr. Sokieta. Treatment with low molecular heparin is recommended, but in case the patients have acute kidney injury or chronic kidney disease, then unfractionated heparin is preferred. Anticoagulate even in acute hemorrhage for 3 to 12 months. NOACs are not recommended as routine. I don't know if this is changing.
It has not changed.
It has not changed. Okay.
Don't have publications.
Yeah, it's not changed. But there are case series now. There are a couple of cases that we touched on. 11 cases reported with rivaroxaban the last 2 weeks. Yeah. So,
The ones are only indicated if the warfarin is coming. That was not.
Then you can
That is information.
we have, to be fair, we have managed patients having drugs, but it's still not the best way.
Only give anti-seizure drugs if they have seizures, and for those with in pregnancy or viperium, in patients with previous history of CVT, if there's no contraindication, then you need to give them low molecular weight heparin to increase risk. Other key points.
So that is a controversial point actually, because the risk of recurrence is very low. Yeah.
Oh, okay.
Yeah. But
So what is it? This guideline, I don't know why they have adopted it. Okay.
Okay, fine.
Unless it's recurrent, but the first
If it's a single episode, the risk of recurrence is very low. In a patient who doesn't have a thrombophilia, non-thrombophilia.
So we just treat for 6 months and stuff.
no, actually, it is either there is controversy. Either the clot clears, that is when we follow up with them like this. But there are people who say the clot doesn't clear from children that blood glands. Others, there's a bit of controversy on follow-ups. Therefore, it depends on school of thought or something.
3 to 12 months, yeah. But 6 to 12 months.
Okay. So endovascular therapy does not improve clinical outcomes in patients with severe cerebral venous thrombosis. Is the other point that I mentioned. With the ability to diagnose, mortality has actually declined to about 8 to 10%, and with up to 80% recover without physical disability. But you can see around 20% still have significant neurological disability occasioned by the cerebral venous thrombosis. The last I mentioned is the genetic stroke syndromes. I was told to add this, I think because there's no other opportunity to talk about them. Dr. Carol mentioned our case presentations, but I just put them here also for reading beyond here. So in their mentions, just one slide, instead of 2 slides. So Fabry's disease is usually a genetic mutation in the that causes
I think, why don't we do this? Why don't we allow people to do that one? Yeah.
Okay.
But I think the key thing message today is sickle cell disease and even sickle cell trait sometimes. I think that is, for us, the biggest genetic risk factor for stroke. So that's something never to lose sight of, especially in a young man with stroke or a young woman with stroke. I think we should think about it.
Okay. So you can go through this and this, and that's the end.
In Miller's, we have a patient here with confirmed Miller's. He's from Mombasa, but he was admitted here in HDU, and he has confirmed Miller's. So it does occur. If you look for it, usually non-territorial strokes, in the setting of usually a history of migraines and seizures, and here the classic track.
Okay. And next we have questions or sessions or additions.